Hi, I'm Jim Nichols. I'm professor of pathology, microbiology, and immunology, and medical director of clinical chemistry and point-of-care testing at Vanderbilt University School of Medicine here in Nashville, Tennessee. Want to welcome you to this session. I'm sorry that we have to do this virtually and can't be face-to-face because that's always a better, more collegial type of atmosphere. But given COVID and all of the restraints on travel, this is best for the time being. So today, I'm going to be describing and moderating the session on AACC guidance document on the management of point-of-care testing. This is a revision to the NACB point-of-care testing guidelines from 2007, and we're going to be talking about the revisions to the management section of that guidance document. I'm the first speaker with this. I'll be focusing on improving point-of-care testing performance through proficiency testing and use of data management. The second speaker will be Ellis Jacobs. He's from EJ Consulting, LLC. He'll be describing the selection of a point-of-care testing system and use of education to improve test performance. Our final speaker will be Dr. David Alter. He's from the Department of Pathology and Laboratory Medicine at Emory University School of Medicine. He'll be describing point-of-care testing implementation and utilization. What is the correlation between reality and theory? So during this session, as well as after, there will be availability to answer questions. So when something pops up, please use your chat box to go ahead and ask a question. We'll be on hand to guide you and to hopefully respond to your inquiries. I want to talk about speaker financial disclosure. I have no grant, consulting, honoraria, or other financial support related to any products mentioned in this presentation. The goals and overview of the entire session is really to explain the role of best practice recommendations and to describe the revised point-of-care guidance document. My particular session will identify key recommendations for proficiency testing and data management to improve point-of-care testing performance. Let's talk about what is evidence-based medicine. Sackett in the British Medical Journal in 1996 described evidence-based medicine as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The Center for Evidence-Based Medicine defines evidence-based medicine as the integration of best research evidence with clinical expertise and patient values. Now, point-of-care testing, when we look to evidence-based medicine in point-of-care, the field is rather young. There's been a proliferation of misinformation that faster is often understood to mean better outcomes without really the research to back this conclusion. There's a lot of hospital pressure to move patients faster. Clinicians want faster turnaround of lab results, and point-of-care is seen as that solution to remove the patient bottlenecks. Physicians want the latest technologies as well, because new technology equates with better patient care, not necessarily research-backed. And every lab really must research the new test requests to determine clinical utility, cost-effectiveness, management, reimbursement issues, and determine how best they will fit in their operations and their clinical settings. So there is really a need for evidence-based point-of-care testing. Clinicians, staff, laboratorians need guidance to apply point-of-care in the most effective manner for patient benefit, and the guidance should be based on the concurrence of the scientific evidence to date. So this need for the evidence-based practice was the concept behind developing the 2007, at the time it was NACB, now it's the AACC Academy, the Laboratory Medicine Practice Guidelines for Point-of-Care Testing. And these are archived on the AACC Academy website. So It has been 10 years ago since those were published, and there is a need to update what was in those and review what's changed, what's new, what needs to be relooked at. Where is the latest evidence? As we look through the various sections of the previous guidance document, there was not much new in pH paper urine dipsticks. Occult immunochemical blood testing, so occult blood in stool using the immunochemical method, and intraoperative PTH are of interest, but there's really no new point-of-care testing devices available. For coagulation, the CLSI just published point-of-care testing, or POCT 14. Drug testing was covered in the recent pain management guidance document. Infectious disease is very hot, particularly with COVID now, and newer molecular tests. But the ASM, the American Society of Microbiology, recently published a monograph on this. Cardiac markers, there is high sensitivity troponin, but it is not available point of care yet. New things that have developed in diabetes is the diagnostic use of hemoglobin A1C. Reproductive testing, there's new premature rupture of membranes, or PROM testing. A lack of fetal fibronectin utility has recently been published in the literature, and urine HCG variant hook effects. That is a separate guidance document that is now being looked at and worked on from a separate committee. So point-of-care testing management also had new literature, and this was seen as the priority by the AACC Academy Board. So we gathered a group of experts and interested volunteers, selected the top questions to ask surrounding what's new in point-of-care management, what do we know in the literature now over the past 10, 20 years that links point-of-care management to improved outcomes, best practice. We then split up the group to search and review the literature, draft recommendations for review and revision by the group. Once we had a complete draft, we posted it for public comment, addressed those comments that were returned, and then the AACC Academy Board of Directors approved those guidance, and we published it in JOLM. We had a very distinguished committee of volunteers. I worked on this with David Alter, who you'll hear from later, Yu Chen from Dr. Everett Chalmers Regional Hospital, Horizon Health Network in Fredericton, New Brunswick, Canada, Scott Isbell from St. Louis University School of Medicine, Ellis Jacobs from EJ Consulting, who you will also hear from later today, Norman Moore from Abbott Diagnostics in Maine, and Dr. Zara Yi, Sanjani Yi from Vanderbilt University School of Medicine, when she worked on these guidance documents, and she is now at LabCorp in San Diego. So let me split up the guidance and the questions that we asked, and then talk a little bit about the literature. We'll describe proficiency testing first. And the principal questions we asked are, does participation in proficiency testing, or PT, also known as external quality assessment, internationally and worldwide in the ISO documents and world, do they improve the quality of point-of-care testing performance? Does the number of tests performed by an operator improve performance on a PT or EQA? And does participation in one of these EQA programs improve patient outcomes? So PT EQA documents that a laboratory can get similar result to their peers in the hands of their own operators. This is real important for point-of-care testing sites with multiple operators, and proving that you can actually give a result that's comparable to your peers. It verifies as well that the test kits that are stored in that site, that location, are stored appropriately, the reagents are viable, devices are functioning, and the staff appropriately time and interpret those results, which becomes very important when you're looking at qualitative type tests that have one line versus two lines, and confusion about whether one line is positive or two lines is positive. PT-EQA surrogate markers for point-of-care testing performance. It assumes that patient test results will be successful, although some samples may utilize a different technique. So depending on what the test and how the PT is actually packaged, take blood gas testing, for instance, you may actually have to open an ampule and transfer the liquid from that ampule into a blood gas analyzer or onto a cartridge where it could be exposed to air, which is very different than transferring a sample that you take anaerobically from a patient, arterial stick, or from a line draw, and transfer it and apply it into a blood gas analyzer or a cartridge. So there is a different technique there. And what we're basically found in the literature is that although it's a surrogate marker, it doesn't necessarily document and prove that you will have successful patient testing performance. Due to the commutability issues, you can't necessarily use PT results to compare performance between different devices. It's useful for judging agreement between labs who use the same methodology, but unless the PT program is commutable between different manufacturers, you cannot use the results to show biases between different laboratories or even performance. Now, many studies document improvement in performance over time, linked to proficiency testing, and this is performance on that proficiency survey. There was a Norwegian study in 2006 to 2015 that showed good performance increasing from 73 to 90% for CRP, 69 to 83% for glucose, and 88 to 94% for hemoglobin. So improvements in the performance and what's ranked as good performance on that survey. PT-INR at 20 sites over 4 surveys improved the comparability amongst those sites. Urine microalbumin in physician office laboratories increased from good to very good from 75 to 90% of results over the length of that study. And error rates continued to decline over time in the CAP-Excel program. So a systematic review of the literature, and we went all the way back to 1945, showed that adoption of quality management, including internal QC, so this is liquid QC that we perform on the analyzers within a laboratory, and participation in an EQA program or proficiency testing program, it actually improves the quality of patient results reported. EQA doesn't itself improve the quality, but it's an excellent system to monitor overall quality and identify areas of the operation that need closer attention and areas for improvement in your total operations. So the recommendations that fell from this literature indicate that multiple studies document improved performance and quality of point-of-care testing when laboratories participate in PT-EQA programs. They actually incorporate the PT results into a total quality improvement program. And third, they act on the trends to identify and correct their mistakes. When all 3 of those things happen, they show improvements over time. So we recommend that all laboratories performing point-of-care testing participate in a PT-EQA program for each test that they perform at the point of care. There are publications that indicate laboratories performing more than 10 tests a week or greater than 100 tests a month perform better on PT surveys and have fewer failures. So we also recommend that sites perform at least this volume, enroll in PT-EQA programs to monitor their performance. And those performing point-of-care testing less frequently should really reconsider the clinical need for point-of-care testing at that location. With multiple operators having to maintain training and competency, if they don't have the opportunity to do the test frequently, are they going to get good test results and quality results that are reliable? Are they going to remember, if they do it so infrequently, how to even operate the device? Third recommendation, there's only indirect evidence that participation in PT-EQA leads to improved patient outcomes. However, the experience gained by participation in the programs enhances staff proficiency with similar techniques that are used for patient testing using point-of-care testing devices. So we recommend strongly that participation in PT-EQA is recommended for all tests, all locations where point-of-care testing is conducted, even in the United States for CLIA waive tests, which are not mandated under CLIA. So that's an important recommendation to take back to your operations and quality programs at your hospital. Now let's turn to data management. We asked three principal questions. Does data management improve the quality and management of point-of-care testing results? Does data management improve regulatory compliance of point-of-care testing? And does point-of-care testing data management, lastly, improve patient outcomes? So with the first question, management of data is an integral part of point-of-care testing. We have patient results, physician orders. We need to link those to operator training, competency, validation of devices, maintenance of those devices, ongoing quality control. Trying to keep track of all this poses a risk of transcription errors with results, duplicative charting when you're dealing with the patient test results, and just managing trends in all of these becomes very complex. Now, most manufacturers have developed proprietary computerized data storage functionality with interface standards to transfer results to hospital and laboratory information systems and what they call data management systems. With the second question regarding regulatory compliance, point-of-care testing data management offers many features to improve regulatory compliance. First generation, for instance, glucose meters had no data management. It was all manual record keeping, and trying to link all of these training, competency, maintenance forms, validation of devices to ongoing quality control and track trends in quality control is almost impossible manually when you're dealing with hundreds of devices. So with second generation, these actually had rudimentary computerization, manual downloading of QC and patient results to a PC. It was what we called sneakernet. Someone had to manually carry a laptop around the hospital and physically connect all of the devices into a PC. But it was orders of magnitude better than manual tracking, because here you could actually track the data, combine it in one database, look for trends, and report results automatically through an interface. The third generation, currently in use, has networks over the internet, data manager computers. You can archive patient QC results, utilize barcoded operator patient ID systems with operator lockout features, competency programs, QC lockout. Collectively, all of these improvements and innovations improve the ability of physicians and nurses to manage their patients with reduced costs, greater accuracy, and enhanced regulatory compliance. With regard to the last question of whether data management improves patient outcomes, by capturing patient results, the data management systems provide the opportunity to generate reports on trends. They can document clinical quality measures, provide evidence of patient outcome. Take, for instance, glucose. You can run reports to look at how many hypoglycemic patients you have, how many are in the hyperglycemic range, how many are normoglycemic. These are trends you can't really do without data management. You can also look at hemoglobin A1Cs. How many times do patients actually come back at the required frequency for clinic visits? There's multiple opportunities to generate reports once you have the data captured and you can manipulate it electronically. Use of point-of-care connectivity allows remote control of point-of-care testing devices from the core laboratory and opportunities to reject patient results when key results are out of range, such as QC lockout. Use of point-of-care testing, for example, in a British emergency department, not only reduced turnaround time for results, but the study noted point-of-care had many advantages, including reliable identification of the requesting physician and assurance of the right result resulted and reported to the right patient. Home use devices now include software enabling patients to share their self-management glucose results and their continuous glucose monitoring results directly with providers over the internet or through a computer. So the recommendations based on the research we found: interfacing, connectivity, and data management are essential components of quality assurance for point-of-care testing. Data management ensures the capture and documentation of all patient and control results, unlike manual transcription, and it results in fewer manual transcription errors. Data management also automates billing. Less staff resources are needed to review results compared to manual logs. So we recommend data management and computerization for all point-of-care testing devices where applicable. Data management systems also automate the ordering and billing of results, generation of control statistics and patient reports, trending of instrument errors, documentation of operator training, competencies that assist point-of-care programs in ensuring regulatory compliance. Operator and control lockout features assure that the QC is analyzed as required and only that trained and competent operators utilize the devices. So the use of data management is recommended to ensure regulatory compliance of point-of-care testing. Now, lastly, data management facilitates the ability to trend patient data over time, compare populations of patients for quality measures, as I mentioned, hemoglobin A1C for clinics, PT-INR, in-range results, monitor hospital treatment goals like glucose averages for intensive insulin protocols. While data management does not directly improve patient outcomes, it provides the tool to collect the information that allows clinicians to better manage their patients. And this subsequently helps improve care. So data management is recommended to document patient trends and to document improvements in patient outcome over time. So I want to leave you with some take-home messages. Best practice guidelines based on published research are available for point-of-care testing. The AACC Academy recently published a revision to the 2007 point-of-care testing laboratory medicine best practice guidelines on management of point-of-care testing. Participation in a proficiency testing external quality assurance program is recommended for all tests and locations where point-of-care testing is conducted, even CLIA waive tests. And the use of data management is recommended to ensure regulatory compliance of point-of-care testing and to document patient trends and improvements in patient outcome over time. I want to show you the Journal of Applied Laboratory Medicine. This is the publication of these guidance documents where you can find more detailed information about the recommendations and the literature that we found. With that, I want to thank you for joining us today. I'm sorry that we could not do this physically because of COVID, but hopefully next year we'll all be together. And at this point, I'm sure the facilitators will turn this over to the next speaker, and we will be available to answer questions remotely from your chat box. Thank you for your attention.
Good morning. It is my pleasure to talk to you today about the recommendations for the selection of a point-of-care test system and for the use of education to improve point-of-care test performance that was recently published in the American Association for Clinical Chemistry Academy Guideline document on the management of point-of-care testing. My presentation will comprise three parts. One, describing the type of assessments and the characteristics or specifications that should be reviewed when selecting a point-of-care test system for evaluation. Then, describe how the evaluation should be performed to identify a preferred point-of-care test system, and not necessarily how it should be performed, but what should be included in that evaluation. And then finally, go over how training and ongoing competency assessment improves the performance of point-of-care testing and our recommendations relative to that. When selecting a point-of-care test system, there are really three questions that need to be addressed. One, what information is needed prior to the selection of a point-of-care test system? how will the test system be utilized? Why is it being implemented? 2, what specifications should be compared when selecting the point-of-care test system for further evaluation? And then finally, how should that evaluation, and again, it's not so much how it should be done, but what should be included in the evaluation to identify the preferred system for implementation and utilization in your institution or clinical setting. So what information is needed prior to the selection of a point-of-care system? What is the first question? Well, we have to look at both the clinical needs as well as the operational needs. And when looking at the clinical needs, you have to ask the questions, how will the point-of-care result be used? What is the true improvement in the availability of the test results? And then how will the point-of-care result be integrated into the practice guidelines, into your order sets, your medical directives, and other critical pathways associated with patient care? We know that the use of point-of-care testing depends upon the need for and the ability to acquire a rapid turnaround time that meets the clinical needs. So when the laboratory turnaround time exceeds 25% of the decision time, then point-of-care testing should be considered. And when rapid therapeutic decisions are needed, really only point-of-care testing may be able to fulfill that turnaround time requirement. In Australia, in a study done in the Western Australia area, point-of-care testing prevented 60 unnecessary medical retrievals from remote health centers to a hospital emergency department. That translated into significant savings, both on an immediate basis and also projected for an annual basis. They projected that annually they would save 13.7 million, 6.5 million, and 1.6 million Australian dollars respectively for chest pain, missed dialysis, and acute diarrhea. In another study that looked at the availability of rapid infectious disease testing, when physicians knew that there was a positive result in the emergency department, it led to very significant reductions in ED length of stay, in the number of additional tests ordered, and in the reduction in unnecessary antibiotic prescriptions, both for cost savings as well as being a component of appropriate antimicrobial stewardship. All very valid and concerns. After completing your clinical needs assessment, you then need to look at an operational needs. What are the staffing requirements for the test? Both the labor required for the actual test performance, as well as that which is required for the management and oversight of the testing. Some of this will depend upon the size of the program. So you have to look at how big it's going to be. What about materials management? What are the storage requirements? You have to look at how big the packaging is, space requirements. What is the shelf life? What temperature do you have to store it at? Is it refrigerated, room temperature, freezer temperature? All that will go into determining how big of a shipment you can get. And of course, the larger the size shipment you get, the less frequently you have to order supplies, and that will have a direct impact on your cost because it can or will change the frequency of acceptance testing. So bigger shipments, less acceptance testing over the course of a year. What about information technology? How is the results going to get captured into the patient record? How's the QC data going to get recorded? What are the exact mechanisms? Looking at the cost, what is the financial justification for the point-of-care test? The needs to be compared against the lab test, and if appropriate, cost savings are obtained, then it's good. But if it's going to cost you more and not have a positive impact on the cost of patient care and directly on patient care, then you have to balance all that together. Then we go to the next question. What specifications should be compared when selecting a point of care test system? We have to look at the test complexity. This will define the educational and needs and the training requirements. It will define the quality control testing, whether it's a waived or moderate test. When we're looking at quality control testing, in addition to the frequency, and again, the complexity will lead into the question of frequency, we also have to look at the space and temperature requirements, similar to that for the reagents. With the QC testing frequency, if it's waived, all we have to do is, at a minimum, is follow the manufacturer's instructions. But if it is a moderate complex test, then 2 levels of quality control have to be performed each day of testing, or develop an IQCP. And in case of something like blood gases, there may be additional testing required if the IQCP is not developed. Look at the device. How big is it? Where can you place it? Is it portable? Is it transportable? What are the electrical requirements? Are there none? Does it require line power? Can it be operated off of a battery? What about waste? Is it self-contained? Does it need an additional system for waste management? What are the maintenance requirements? Which then lead into labor as well as complexity of the system and other areas where there could be problems associated with future performance if the maintenance is not maintained or done properly. What about operator management? Does the system maintain a list of competent operators and only allow authorized operators to operate the system? Does it have a QC lockout? Will it prevent test performance if quality control has not been done in the time frame as required by your protocols? And additionally, not just that it has been done, but that it's within range. What is data connectivity? Does the system interface directly with your LIS or EMR, or does it go through a data manager, or none of the above, and you have to manually enter the results and collect them through SneakerNet? Specimen, urine, easiest sample to obtain, non-invasive, finger stick, venipuncture, arterial sticks. What are the anticoagulants that are required? And sample size. And then training. The extent of training depends upon the complexity of the system. What are your anticipated number of operators? Can the training be done by your point of care personnel, or do you have to use a train-the-trainer program for larger systems? And then talking about very large point of care programs, does the vendor provide assistance in at least initial training to get the program off the ground and running? All these are important questions that need to be answered when looking at the selection of a point of care system. So then, after assuring that the systems have validity, that they meet certain basic needs and requirements, what should be looked at to evaluate and identify that system that you want to actually employ in your test program? You have to look at the analytical performance. Look at the accuracy relative to lab reference method, looking at patient comparisons, looking at clinically acceptable bias. What is the total allowable error? Especially in the case of quantitative methods, What is the within run and between run imprecision? Does it meet the clinical needs? Is the test being used for screening purposes or diagnostic purposes? All that will play into what are your acceptable biases and acceptable errors and imprecision. What is its linearity? What is its analytical measurement range? How frequently will you get samples that are above the limit and that you then need to reflex to a other method, usually a lab-based method, to get a final result? And what about specificity? How many compounds interfere with this system, and what are those interferences, and how significant are they? Costs. There are startup implementation costs, and then there are operational costs. We know that the startup implementation costs can be quite extensive, especially with training and validation of all the different pieces of equipment. And then you just have your ongoing operational costs. And finally, but not least significant, is end user acceptability. How well is the system accepted by the end user? Do the nurses or whomever is going to be using the system find it easy to use? Do they feel comfortable with it? Because their utilization and their acceptance is very critical for its success as a program. You can have the best system out there from an analytical perspective and from an operational perspective, but if the end users don't accept it, then they can kill its success as a program. So when selecting a point-of-care test system, the recommendations are: 1, that an operational and clinical needs assessment needs to be performed, as well as a review of the facilities and materials management requirements to identify the use characteristics that are required in the potential point-of-care device, or I should say devices. You need to create a detailed specification that includes the number of samples to be processed, what are the sample preparation requirements, what is the size of the instrument, what is the maintenance requirements, how are consumables stored, what are power requirements, and if it's an instrumented system, what are network ports for interfacing into your LIS EMR system. And then finally, you need to develop a framework for introducing the new technology to the healthcare system. And that framework should include that analytical and clinical accuracy assessment, a clinical validity and utility determination, and an economic evaluation. As long as that framework is properly developed and implemented, and then you should be able to properly select a point-of-care system for use in your institution. So now let's move on to education. There was one basic and simple question that was asked. Does operator education, including both training as well as ongoing competency assessment, improve test performance? You may say that that's an a priori truth. It makes sense, but there was up to recently there was no hard evidence to prove that or justify that. We know that one of the challenges of point-of-care testing is both in ensuring and maintaining the accuracy and reproducibility of the tests, especially given the potential sizable numbers of operators and instruments. We know that there are glucose programs out there with hundreds of instruments and thousands of operators. Maintaining that competency, maintaining the consistency of test performance across such a large and vast program is a challenge. It has been observed that users who perform fewer QC tests generate results with greater imprecision. So that indicates that user competency was a significant factor in affecting analytical performance. In one study, most of the clinical nurses reported that the training they received improved the quality of the glucose testing and their understanding of the significance of quality control. And they were able to show that, or not to show, but have imprecision that was equivalent to laboratory imprecision, and that over a period of time, that imprecision actually improved. Not a lot, but definitely there was improvement, where it went from a range of 2.4 and 3.7 to 2.4 to 2.8, with the lab having a performance at 2.6%. So there was a very definite improvement in the ability for these nurses to perform the quality control testing. A sub-study showed that comparison of tests performed by trained and untrained nurses using the same type of instrument and the same lot of glucose strips, that the performance by the trained nurses was better than that of the untrained nurses. 4.5% in precision versus 6% in precision. Again, you might be saying this makes sense, but again, there is no specific data to show it up to now. In Australia, a system was developed to support point-of-care testing for both urine albumin-creatinine ratio and hemoglobin A1C testing across 100 sites. And this system included a comprehensive program in education, training, quality assurance, and ongoing management support. Every 6 months, 12 quality assurance specimens, what we call here in the United States proficiency testing specimens, were analyzed for precision and accuracy. They were able to obtain performance equal to the central laboratory within a 2-year time period. Very good. And comparison of glucose meter performance, and another Loc site, before and after educational intervention, found that the average total error decreased. In that study, before the intervention, some of the meters had biases greater than 20%, most showing a bias greater than 10%, and that after the intervention, there was a significant decrease in the average total error for all meters to a range of 5.5 to 7.6% for the low control, and from 4.1 to 6.5% for the high control, showing that education definitely did improve the performance of the testing. So we have seen that multiple studies have concluded that a single training event is not sufficient, and that ongoing training and support from the laboratory is needed to improve test performance. In a CAP-Q probe study on bedside glucose monitoring, it was found that institutions with a policy for scheduled performance review or for scheduled repeat ongoing training had better performance than their counterparts. So the recommendation of the Academy is that point-of-care test programs maintain ongoing training and support for the clinical staff in conjunction with consistent monitoring of test performance. So there are really 2 takeaway messages that I'd like you to take away. 1, that appropriate selection of a point-of-care test system requires a clinical and operational needs assessment done in conjunction with an analytical and clinical accuracy assessment, as well as a clinical validity, utility determination, and economic evaluation. And 2, initial and ongoing training and competency assessment are essential for obtaining and maintaining quality point-of-care test analytical performance. And with that, I will conclude, and I look forward to your questions. Thank you.
2 point-of-care testing management issues that get discussed often in the hospital setting are the need for an interdisciplinary committee and does point-of-care testing improve processes and outcomes? That is to say, what is the correlation between reality of actually using point-of-care versus the theory of faster turnaround time testing? With respect to the interdisciplinary committee, we just broke it down into does an interdisciplinary committee improve the quality of point-of-care testing, and does an interdisciplinary committee improve patient outcomes? In the CLSI guideline document POCT04, Essential Tools for the Implementation and Management of a Point-of-Care Testing Program from 2016, a list of interdisciplinary point-of-care testing committee responsibilities are listed. And a multidisciplinary committee is recommended as a key feature for continuous quality improvement. The committee should promote communication and cooperation between all involved professional groups, such that there is shared decision making for the appropriate selection of tests for the appropriate patient populations in the appropriate settings. The committee should also promote that all regulatory requirements are followed and ensure that they are met for everybody, as well as that all protocols and procedures are correctly followed. With respect to procedures and policies, the committee also serves as a forum to address potential changes that might be needed for the self-same protocols and procedures, changes that can be made in a collaborative effort or be explained to the group why changes aren't a sound or practical or regulatory wise move. Committee membership should include representative shareholders from all ends of the point-of-care testing spectrum, from the laboratory to the end user, not leaving out groups in between, such as biomedical support from the hospital, supply chain issues, supply chain areas from the hospital, and so forth. So does an interdisciplinary committee improve the quality of point of care? Well, it is recommended. It makes logical sense. And even though the data is limited, there is a study that showed pre and post implementation. There was a 4-fold drop in pre-analytic errors at one institution. At this institution, they also showed that there was an improvement in proficiency testing and other quality metrics. The next question was, does an interdisciplinary committee improve patient outcomes? Improved outcomes potentially decreased morbidity, decreased mortality, faster treatment, better care. The evidence was very limited. However, there's a gestalt in our discussions that revealed that an interdisciplinary committee would allow for the flow of information to improve care for patients, especially with key analytes such as hemoglobin A1C, HIV, sexually transmitted infections, and respiratory tract infections. These groups stand out because rapid treatment is important and available, and follow-up may not be available due to the critical populations that they may be used with. So, does the interdisciplinary committee improve the quality of point-of-care testing? We consider that the committee is essential for a successful point-of-care program, point of care operators and clinicians are outside of laboratory medicine, and most of them lack medical laboratory training, but can contribute expertise and experience in other clinical areas and/or administrative and patient care duties. Committee participation from other disciplines is valuable and should be invited under the leadership of laboratory medicine. We recommend the oversight of an interdisciplinary committee for all aspects of a high-quality point-of-care testing program. Does this committee improve outcomes? Limited evidence that an interdisciplinary committee would lead to improved patient outcomes. However, again, the experience and knowledge from the other disciplines will help the laboratory implement and manage the point of care to meet the accreditation requirements and in turn provide better service to its clients. With respect to an interdisciplinary committee, I can't say this often enough. The interdisciplinary committee should be the cornerstone of all point of care testing efforts in a hospital situation, as it will allow and promote better communication and cooperation in a collaborative format between the different professional groups that are involved. It will serve as a tool to remove all shareholders from their individual silos so they have to discuss the problems together and come to solutions. The next thing that was looked at that I'll be presenting today was, does point of care testing improve processes and outcomes? Or rather, point of care implementation and utilization. What is the correlation between reality and theory? Often we hear that point of care testing is necessary because the rapid turnaround time will allow for better patient outcomes and better care overall. However, the evidence on this needs to be investigated. For this segment, I broke down point of care into improving processes and improving outcomes. Processes involved with patient care management, such as decreased admissions, increased discharges, decreased length of stay. Outcome associated with changes to morbidity and mortality, as well as change in treatments. The intent of this review was to determine what literature evidence exists to support these contentions that faster turnaround time will lead to improved processes and outcomes. A literature review was done with the intent to identify what available evidence existed, using PubMed free text search to identify as many references as possible, excluding references that were strictly point of care method validations or promotions for hypothetical or proposed utilization of point of care testing, or literature that introduced new ways to use point of care testing. Key in the literature identified were multiple reviews articles that examined the evidence to support the use or not of point of care testing. The primary meta-analytic review studies are listed here. Of note, Florkowski, point of care testing and evidence-based medicine, does it leverage any advantage in clinical decision making? Patel and Sulailam, implementation of point of care testing in a pediatric healthcare setting. Pecoraro, point of care testing, where is the evidence? A significant systematic survey, as well as St. John, the evidence to support point of care testing. These review studies were used as the basis to branch out into other related studies. Upon review, that they covered most of the other studies that were also seen on my PubMed searches. Sorry. With respect to creatinine, there is theoretical hope that point-of-care creatinine can speed up the processes in imaging suites with creatinine available at the time of testing. However, no studies were identified. After the publication of the guidance, another reference turned up that showed that point-of-care creatinine testing in the emergency department did reduce the prescription of nonsteroidal anti-inflammatories. With respect to drug of abuse testing, one study was identified that showed use of that resulted in a decreased length of stay in the emergency department. With respect to human chorionic gonadotrophin, HCG, one study was identified that showed no reduction in emergency department length of stay. D-dimer implementation in one study showed decreased admissions and increased discharges in the management associated with pulmonary embolism, or not. Rapid flu testing identified numerous articles supporting its use in the emergency department as well as urgent care clinics, that the use of point-of-care flu testing, rapid flu testing, decreased admissions, reduced antibiotic use, reduced overall lab testing, and did increase the use of antivirals. With respect to rapid flu testing in terms of length of stay, there were some mixed results. But the use of the rapid flu and its impact on processes was seen in multiple studies with consistent findings. The use of point-of-care testing in the emergency department, urgent care, non-influenza, showed some cases of decreased length of stay. In others, it was not identified. One study showed even that the length of stay increased. Personal observation on mine on reviewing the studies, that length of stay appeared to be decreased when a process was modified to take advantage of the rapid result. With respect to outcomes, there were no studies identified that point-of-care glucose improved inpatient outcome. The use of point-of-care testing glucose in the inpatient environment is well known and well utilized in the management of tight glycemic control. However, I was unable to identify any studies that discussed inpatient tight glycemic control relative to point-of-care testing and outcomes associated with it. Please email me if you have seen any such studies. Hemoglobin A1C, multiple studies confirmed the benefit of point-of-care hemoglobin A1C testing as a patient-physician satisfier for treatment monitoring, such that the determination of a patient's hemoglobin A1C while visiting their provider would show in real time whether they were in control, good control or not, allowing the provider to adjust their treatment regimen and educational efforts. With respect to blood gas electrolytes in the intraoperative arena, there were no studies identified. With respect to blood gas electrolytes in the ICU emergency department areas, there were varied results as to whether or not results improved outcome. One study did show faster clinician decision time. However, it did not change patient outcome. With respect to troponin, there were several studies that showed improved outcome when used in rural/remote settings where point-of-care troponin results were able to stratify patients for risk and determine which patients needed to be rapidly transported and which ones could be held for observation. BNP, NT-proBNP. No studies identified that showed patient and improved outcomes with point-of-care testing of those. Hemoglobin, point-of-care testing. One study showed that it reduced transfusions in the NICU population. No studies were identified with point-of-care testing for platelets, ACT, or thromboelastography. Yes. Sepsis. The use of point-of-care lactate in one study did reduce ICU admission time and improve mortality. With respect to locations, there were multiple studies that studied point-of-care in remote locations that showed that it would reduce transfers, increase the diagnostic certainty at remote locations. This also was overlapped with the troponin studies. There was no clear literature on the use of primary point-of-care and primary care practice, nor from the use of community pharmacy. So, does the faster turnaround time secondary to point-of-care lead to improved processes and outcomes? Arguably, point-of-care does generate faster test results, turnaround time when compared to the central lab secondary to the markedly reduced collect to in-lab and in-lab to result segments. In turn, end-user clinical providers, especially those in time-sensitive critical care, such as the emergency department and ICU clinical areas, believe that faster turnaround time necessarily translates into improved patient care because there is the opportunity for quicker clinical responses leading to better patient outcomes or quicker patient care process, hence their desire to continually expand point-of-care methods. It has been shown in certain studies, and depending on analyte and condition, that faster turnaround time secondary to point-of-care testing can lead to improved processes and conditions. However, in the non-rapid flu influenza categories, the studies are mixed. I believe, personally, that it does have the potential to do so, but that processes need to be adjusted to handle the rapid result so they can take the full benefit of it. Thank you very much for your time. Reduced collect to in-lab and in-lab to result segments. In turn, end-user clinical providers, especially those in time-sensitive critical care, such as the emergency department and ICU clinical areas, believe that faster turnaround time necessarily translates into improved patient care because there is the opportunity for quicker clinical responses leading to better patient outcomes or quicker patient care process, hence their desire to continually expand point-of-care methods. It has been shown in certain studies, and depending on analyte and condition, that faster turnaround time secondary to point-of-care testing can lead to improved processes and conditions. However, in the non-rapid flu influenza categories, the studies are mixed. I believe, personally, that it does have the potential to do so, but that processes need to be adjusted to handle the rapid result so they can take the full benefit of it. Thank you very much for your time.
Well, welcome to the question and answer section of this management of point of care testing session. So I'd encourage you to submit your questions at this time. We have a few that can get us started with the discussion. I'm going to start off with the first one here. Is there any guidance recommendation on how many tests should be performed for operators to remain competent? And if so, at what frequency? Well, I can say that in the literature that I pulled with regard to PT and external quality assurance programs, there was at least 2 publications that looked at sites that were doing point of care testing. And if the site did at least 10 tests a week or a minimum of 100 tests a month, those locations performed better on proficiency surveys than other locations that had less frequent testing. They didn't specifically look at an individual operator and what the minimum was that an operator needs to be doing testing to remain competent. And I'm certain that that probably depends on the complexity of that device. Alice, Dave, do you have any thoughts on this?
Yes, actually I do. I don't have any literature perspective. I know from personal experience when I was in charge of the glucose testing system at Mount Sinai many years ago, we saw in the monthly QC statistics that those sites that were doing less than 100 tests a month definitely had much higher imprecision on their quality control testing, which we used as a surrogate to indicate the competency of the individuals to do the actual patient testing. And that translated to basically less than 1 specimen per day per operator. So definitely you need to have, in my thinking, a person has to do the test at least once a day to really maintain competency.
I'd like to, before I give my answer, just apologize for my discordant slide narrative. I did check it before I submitted it, and it seemed to be working fine. So let me apologize at this point. In terms of number of tests and competency, it makes sense that the more tests you do, the better you'll get. And if you do fewer, then the competency will drop off. I would have to ask that if you needed point of care in the first place, doesn't that infer that you'll be doing the test often and require it? So if you're not doing a lot of point of care tests, then I have to ask myself, why did you need the test in the first place? Unless it's a niche critical situation like a neonatal transport unit.
Yeah, and I see, we get requests from clinics and different locations where they want every single person that works at that clinic trained on point of care, just in case they're called upon to do the test. And that becomes a concern because they really need to have the opportunity to perform the test to get good at it, as we're mentioning. So I think, is there a sweet spot? I think it depends on the institution, and certainly there's no literature out there to support, other than proficiency survey performance, individuals and minimum that's needed to remain competent.
I would add.
It's interesting. I heard an anecdote in the COVID-19 area where at one hospital that I have not at and have not been at, the respiratory staff who had done most of the critical care point of care were downsized due to the number of patients. And to make up for that, the ICU nurses, some of them who had a lot of extra time on their hands, were then trained up in performing the point of cares to sort of make up the difference, to maintain their just in case and also to expand their capabilities.
I was just getting ready to say, it also depends, I think, on the test and the system that's being employed. We do know that some point of care systems are a little bit more complicated to perform than others, either whether it's sampling technique or actually operational technique of the system. So that also plays into how frequently an individual needs to do the test to maintain their competency.
And I'll add to this that, a lot of the operators that are being asked to perform point of care testing are some of the lowest level of staff. They're sort of pushing that task downward in terms of the tasks and the availability of staff. And you certainly need, while it's CLIA moderate complexity says you need at a minimum a high school diploma and some on-the-job training, these are medical laboratory tests that are being used in the clinical management of patients. And you need some minimum medical knowledge as to interpreting what that result is. You can't make a determination that I did something wrong if you don't even have an idea of whether a result's elevated, not elevated, and what that result generally means in patient care. And from that perspective, we don't necessarily encourage PCTs or the patient care technicians, the MAs, all of these individuals that are simply high school trained with on-the-job sort of orientation to tasks on the unit. We don't necessarily encourage them doing ISTAT testing, blood gas testing, other things that are more moderate complexity.
Right. And I think that's a point that we all, those of us in this conference or this session, should remind our end users that when your PCT or your nurse or anybody is doing a point of care test, they are essentially the laboratory technician, a MT, a med tech in the moment, if you will. So we attribute to those operators the same requirements that we would attribute to med techs. And I sometimes have to remind the end user staff that this isn't just a simple plug and play, put a drop of blood on a strip device. This is an essential, a miniaturized laboratory that you're operating. So you have to think of yourself in that perspective, change hats, if you will, for a minute.
Well, let's move on to the next question. It's somewhat related. They said that they agree 100% that a robust data management system is the key to increased patient safety and less risk. Some devices fall short of this and have not been updated in years. How can we as a collective group push vendors for better data management capabilities on the point of care devices? Ellis, Dave, I'll throw that out to you first.
Well, I would, push that old systems that you try to employ are, quote, POCT 1A compliant, which is a point of care from CLSI, which is a document on data management capabilities of the systems at a minimum. And putting my old industry hat on for a second, the other thing is you just have to keep pushing it to the vendor whenever they have any type of Q&A sessions, if they're doing outreach where they're trying to get feedback from operators on development of their next generation device. Keep pushing it hard that is what's needed, because it's only by hearing it from you as the end user, as the consumer, will they make any changes, because they're not going to make any changes if they don't feel it's of value.
Data management systems are key, but the backside or the dark side of data management systems is that you then have to struggle with the interface issues associated with your particular laboratory EMR or your laboratory information system. And sometimes those add on, I would have to argue, geometric increases in cost in terms of both the package as well as the resources in your hospital to implement them. So yes, for data management systems, but sometimes they're financially difficult to install. tell you that a glucose data management system is absolutely the best that you can get. You have to get that because you're doing so many every day, all the time. But there are some very good data management systems out there for less used tests, which would probably improve their use, but I've seen them held off by hospital administrators because the cost isn't worth the benefit on a bigger scale. I'm not going to mention the test of the manufacturer, but I'm sure that users can think of their own examples.
So let's turn to another question here. In terms of operational perspective for point of care testing, was there any evidence to suggest the number of point of care coordinators necessary for a point of care testing program? And is there anything for the number of point of care coordinators correlated to testing method, devices, volumes, improved regulatory compliance, or patient outcomes? And indeed, we located no literature to average, what is needed in terms of point of care coordinators to supervise ongoing management of a point of care program. It's something I know that a couple organizations are looking at questionnaires and sending around to see what is the state of the art, but certainly there's nothing in the literature currently.
Right. And on the artery and its predecessor, the AACC listservs, that was a repeated question often where users would try to match how many coordinators do you have relative to the number of beds, to the number of tests, to the number of point of care tests. There was a lot of variables involved, and there were some ad hoc surveys on the listserv. I don't know if they've been well repeated on the artery point of care form, but there was trying to match up coordinators to number of devices, to number of beds, and so forth. I've seen 4. I mean, at Emory, we have, at Emory University Hospital, I couldn't tell you the number of devices or beds, but we have 4 FTEs responsible for point of care. And at the other Emory Hospital Midtown, Emory University Hospital Midtown, I believe there's 3 or 4 as well. It really depends upon how your administration is committed to supporting point of care.
I think that's the key to it, that you have to get the administrative support. When I was at Mount Sinai, when I was there, we had 16 different point of care test systems in operation. And we had 5 FTEs associated just with point of care testing. I had called them, one was the coordinator, and the other ones were point of care chemists, I called them. But this was also before data management was available, so we used the sneaker net. So they would also have to go around every month, pick up all the data sheets, enter them into the information system, review the quality control data. So there was a lot of manual work that was being done by those 5 individuals. So it's very unique to your institution and how you have your point of care testing program established. As Dave said, there is no clear-cut guidelines out there to say you have so many tests, you have so many operators, you have so many systems, therefore you need so many people to support it.
I would also add that if you were charged with increasing or adding point of care coordinators or point of care staff to your department, I would make the case that you should go for individuals that can be either full FTEs, and if they're half FTEs, it means they're only there half the time, not half on the bench and half doing point of care. I think the dedicated point of care individuals provides a lot better service, and I think everybody would agree that they need to be focused on point of care and not wondering whether they're going to be on the heme bench tomorrow and doing point of care today.
Exactly. I'm going to jump down to a question here. Some of us subscribe to JOLM, and some may not. How do those who don't get a copy of the new guideline to help provide evidence-based information in the hospital setting? Basically, you can go on to the AACC Academy website at aacc.org, and these guidance documents are posted there. So you can pick them up off the AACC Academy website. There's another one here that's a very relevant one. I know that we've been challenged with this as well. We have had to switch to more online training modules due to the pandemic. Have you noticed a difference in operator performance with hands-on versus online training? I think that you have to be careful, and I'll jump in to start the debate about this one. You have to be careful because training is one thing, competency is another. And as we look at competency, there are 6 elements of competency that the CAP, that CLIA have recommended. And those elements, one of those elements is actually visually watching the person do the test and being able to troubleshoot and document results and do the other aspects of the entire procedure. So, you know, doing it through Zoom isn't quite like being there with it. And I know that even with the social distancing and with COVID, we have not foregone in terms of our competency checks, making sure that it is done in person rather than online. You guys want to jump in about that?
Well, we still work as a team if you're a healthcare worker on the front lines. So I don't see how the round robin method of ensuring of visualizing competency or observed performance would change at all, because we still, you know, are still out there all the time. Now we're just wearing masks and gloves and face shields and so forth.
Ellis, any comments?
No, because I haven't had any recent experience of this, so I can't really comment.
Okay, the last 2 questions are sort of related. I'll read the 2 of them together. The Point of Care Committee oversees the evidence-based clinical application of analysis and testing. The actual oversight is within the Department of Pathology. Point of Care Coordinator, the manager, reporting directly to the pathologist, report up to the Point of Care Committee for ongoing and new implementation of point of care processes. I was wondering if one of you could describe how you set up a Point of Care Advisory Committee and how it works and has evolved in your institutions. Dave, you want to start there?
I want to admit that at my previous location, we had a more of a Point of Care Advisory Committee. Well, actually, no, we have both, and we sort of have one at Emory as well. I think, again, it's commitment from the leadership to support your desire to get individuals from the other services to sit on those committees and to be committed to coming to share your needs. At one place, we didn't have an individual from biomedical or support or supply chain, but we reached out to them depending upon what our needs were and if there were shortages and so forth. Again, it's a commitment and desire.
Ellis, do you have any comments?
We had set up our Point of Care Committee with the laboratory, myself at the time as the chair of it, but we definitely had representation from nursing education, physician, infection control, diabetes, since it was predominantly glucose at the time. We had diabetes nurse educators on the program, IT, materials management, and then when we needed specific individuals, unique, for example, when we were working with cardiac tests, we would bring in somebody from the specific clinical unit that was associated with it. And all test requests, all system requests had to go through the committee, and they reviewed it and either approved it on a permanent basis or on a tentative basis. And it worked well because the key was that we had full support from upper hospital administration. And that, I think, is the key to success. If you just try to do it alone as a laboratory, then people see it's just laboratory pushing themselves into other people's faces, into other people's areas. But if you get your hospital administration saying, no, this is something that we buy off on and that we totally support, then you'll be successful.
Now, in terms of a point of care committee, we did have that full body representation when ER was requesting point of care troponins. So the relevant actors were brought together in one room over several meetings when we were having that discussion, but it was not a standing body, if you will.
So ours kind of grew organically. You know, it was the laboratory having to take on the regulatory aspects. We needed nursing input on this. So we got nursing leadership to appoint a couple of individuals, and they were naturally interested in this because they wanted to make sure it was being done correctly. And it sort of grew from there. We started adding on nutrition, pharmacy, as particular tests required more input. Certainly, I think purchasing and the distribution centers so that they could manage the lots as they were coming in and sample those or send us samples to validate new lots and new shipments, because we were not in the area that was receiving. It was important to have a representative from them on the committee. So it sort of grew that way. I'll jump to the last question here that we'll take. It says, with the literature indicating that point of care testing does have a clinical impact for some tests, where do we go with the point of care tests that did not have clinical impact? In other words, how do we convince physicians, units, they no longer need to do that test at the point of care? And I would say you should routinely go back and reassess the testing that you're doing. Give the example of gastrocult. We have largely gotten rid of all the gastrocult testing. It still remains in the laboratory should they need one, but we got the experts who are GI individuals, the gastroenterologist involved, asked them, do you really need gastrocult? And virtually every one of them said no. If it's a bleeding, overt bleeding is evident, it's a medical emergency, and that's going to be handled. The reason why they had the gastrocult was because it had pH as part of the test. They used it during the placement of NG tubes to make sure that the tube was actually in the stomach and hadn't punctured or wasn't too far in or hadn't gone down into the lung. So they would use the pH portion of the gastrocult test and not the occult blood portion. So pH paper was cheaper. We got them to use pH paper that they were already trained on, and that was easy to get rid of the gastrocult, because they said they never looked at the gastrocult, the occult blood portion of the card when they were placing tubes, because virtually all of them were positive just by the trauma of inserting the tube. So I guess you have to ask the question, really, how is the test being used, and reassess, is it being used effectively throughout the institution? But that's an example. We've been getting rid of ppm in a lot of our outpatient clinics because we now have molecular diagnostics that is more sensitive, and they can send the test to micro for that. So, it just depends on the test. You guys have?
Every request for point of care that we don't have, that we don't already have, that is a new test, I always like to approach it with the phrase, and I think many of us do this, I see your request as an opportunity for improvement. So if this is for an inpatient or emergency department point of care test, I think we all do, try to shift the onus back to the requester to say, what are we doing not well in the main lab that should obviate your need for a point of care test? And sometimes they can modify their processes and realize that they didn't need a point of care test. And sometimes it opens up the door for them to modify their processes so that they can better use the point of care. nobody will argue that point of care gets you a faster result. The question is, does the implementation of the point of care test, the faster result, change your process significantly to get a better outcome?
Absolutely. A key question that needs to be asked whenever a request for a point of care test is made is, why doesn't the current testing system meet your clinical needs?
Exactly.
And then based on the answer, you decide, do you change your current processes via the laboratory to meet those clinical needs, or do you implement point of care testing to meet those clinical needs? And conversely, on a periodic basis, once you've approved a point of care test, you should reevaluate, does the need for it still exist? Or has things changed to the point that, you know, as both Dr. Nichols and Dr. Alter have said, situations, methodologies have changed, and therefore the need has been obviated.
Mm-hmm. At one institution, we had kept the point of care pregnancy testing out of the ER because they perceived that it would improve their turnaround time being able to get a result. But we showed them that the patient getting the result in the examination room didn't change their turnaround times that much. So ER went back and relooked at their processes, and instead, for the right patient population and situation, would get the pregnancy test at triage. So that when the patient got to the treatment room, they already had a pregnancy test result in hand. And that did speed up their process, as opposed to not changing anything with getting the test in the room after being clinically evaluated.
Well, I want to thank everyone for your attendance to this session. Ellis, I want to thank you, David, for participating both in the drafting of these guidance documents and in this presentation. And I want to thank everyone for their attendance and hope that you take home something worthwhile that can improve your institution after this session. So thank you again.
Thanks.
Thank you.
Thanks, everybody, and thank you, Jim, for including.
Yes. And everybody have a good remainder of the meeting virtually.
Absolutely.